It's made me think that we need to think about this, that if we can't wait and have this problem come up on us after it's full steam. So what we're going to be talking about today is pursuing a mystery, and the mystery is age. And as you look at it and say, I look at all the audience, I'd say, well, you folks look at this and say, well, I'm a long ways away from that. And I'll tell you, it goes pretty fast, it catches up with you. And as we look at it, I say I have no disclosures, nothing to declare here on this thing. As we look at our population and look at one another and see what happens is that aging is a series of changes that we go through. And as you look at this, as you look at in general, life starts out where all the changes are fairly positive, that you're growing, you're becoming more mature, the changes are things that you are pleased with. But then toward the latter part of our life, we begin to have changes, but these are deficits. We begin to lose something. We begin to lose our hearing. We begin to lose our vision. These are things that happen to us as we go through. Now, we think that we can look at chronological age and say, we've figured that one out. All you have to do is look at somebody's birthday and count the birthdays, and you've got their chronological age. But I think that this is a rather profound statement that was in the New York Times back about a year ago, and saying that we're really fairly murky about what the biology of aging is. People have talked about it and said, is it an inflammatory disease? Is it, oxygen stress? Is it, similar to coronary disease? There's all kind of things that have been tossed around, but nobody's been able to look at it and say, this I understand is the biology of aging. Also, we do know it's inevitable, and so far I think we've found nothing that would change and make us go another direction. This maybe is a different look at aging, but again, it's showing you what happens over time. The striking thing is the first part of aging we look at is the population is shifting in their age. And as you look now, 10,000 baby boomers a day, that's a phenomenal number, get Medicare, sign up for Medicare. And so that means 10,000 people in the United States a day are reaching the age of 65 or more. The other thing that you can see, and I think if we looked at the last graph here, would be this part of the slide, you'd see that we go in another 2 years, there should be more people that are over 65 than there are under 5 years of age. So this is what's happening to our population. It's not only that we're having people getting older, but we're having a dramatic shift from the very young to the very old. As you look at the U.S. now, a man that reaches age 65, you can expect to live to 84. A woman who reaches age 65, expectations is she would be at reach 87. 87. The people that study aging break it down into these groups, and I think there's no merit in doing it. I think that we're past this thing. Again, this refers to chronological age, and there's not much that we need to attach to that now. I think we've got to be looking at aging in a much different way. And one of the mysteries, the first mystery you say is, why is the population, the elderly population, grown so? And the first thing you'd say is, well, people are just living longer. But all the people that study aging have looked at it and did not expect the ballooning that is the group of people that are growing the fastest are people that are over 85 years of age. More of those than there are people at 65. And so why that dramatic bloom is people don't understand. The other thing that we come through to this is one of the persistent mysteries of aging is why some people can age so very well and others do not. This is something that comes to us as we look at it, is there's a group of people that come into aging and they have a higher mortality over the next 3 years than all those around them. And it's a striking higher mortality. It's about 6 times different here. I would say that this is what we call frailty. I need to ask the gentleman in the back who's running the slides, is we're missing some of the slides here. They're jumping over. You don't see another. I can talk without it, but it's. We'll go forward and leave it come out. I think I can cover the points. What does frailty really mean? And what we're talking about is we're taking population of people that come in and we're looking and saying, you're old, but you're much older or you're much more debilitated than your peer next to you. And when we say that, you're not looking to say that they necessarily look more frail than the person near. That's a part of frailty we're talking about, is that you've got to be looking at a patient and saying, I can predict from some way that your life expectancy is much shorter than everybody else's. And we'll talk about the ways that it can happen. But frailty means that these people are subject to adverse consequences of any illness. It also says in the same sense that they're very vulnerable. That if you have two 85-year-old people, one of them would get the flu and not recover from it. The other one would get the flu and be in bed for 72 hours and back. And so what's that difference? And it's not a difference that necessarily is apparent. Also, your reserve capacity is limited. That is, that you come and you put it in some stress, whether it's a family stress or personal stress or this type of thing, then you don't handle it as well. And then the final point is frailty identifies the people that we do not address for the most part today, and we need to do that. We need to figure out how can we help them. So the American Geriatric Society, and Ted Johnson certainly knows a lot about this, is looking at frailty and what it means. And these are the various components that you're talking about. It's a physiological syndrome, diminished reserve, you have a cumulative decline over multiple things that are going wrong with your body, and you're very vulnerable to a bad outcome. This is the physiology of it. Now, if you look at this is the way it looks in the diagram. The thing that is the most important in causing frailty is what we call sarcopenia. And sarcopenia is, of course, derived from Greek, and it talks about muscle weakness. Now, a lot of people think that you lose muscle mass. So it's not necessarily muscle mass loss. It's a change in the muscle, that you have more fatty deposits in the muscle. You have more, the neurological consequences of trying to contract are delayed and slow in these people. But their muscle mass might be the same, but it is the difference. And most people look at sarcopenia and say, that's the thing that started frailty. But if you look at this graph, you can see that it could have started at any place. It could, you could start the first very thing that you're doing is you're losing weight. And you begin to lose weight for unapparent reasons. It could be that you get very slow, that all your activities, your motor activities begin to slow down. And we'll talk about ways to measure that. Your strength falls. You begin to get subject to falls and injuries with that because your balance is changing. And these are all things that are happening. And what we do right now is we usually don't pick these up. The patient comes in, elderly patient, has a complaint. We try to address the complaint. We don't look at some of these other things. And when we're subject to these people to some years ahead of very poor health. So this is what could happen. Say if you were looking and you had a fit older person. The fit older person would come along and you know that they're independent. They're leading a life, and they come through and they have a minor illness. They sag a little. Functional capacity is decreased a little, but it rebounds very quickly. You look at a frail older person, and they're right at this point independent. They're doing well. You wouldn't pick them up necessarily just by looking at them. And yet when they have an illness, say the flu or some other illness that comes through, then what happens to them is that they have a marked deterioration in function and have a very slow recovery during a time that they are very dependent on other people. Sometimes they never get back to that. This is another graph that shows how people with sarcopenia can do, is if you have this point is normal aging. Normal aging, as we said, past the Middle Ages is a time of some decline. Various speeds and this type of, but there's a decline. What can happen with the frail person is every time they have an insult, then they drop off in their functional capacity and they don't rebound back up to where they came. Another insult, they fall more. Another insult, they fall more. And then some of them have a little rocky course early, not a very significant illness, but that sets them on a pathway that they're declining in their health much quicker than other people. And this is what kind of it fools us, is we don't pick up necessarily these people when they come in, and that's what we need to try to do. How can we, as a medical people, look at this and pick up these people and say, you're the one that needs help. Now, there's problems with saying you need help is we're not sure at this point. We'll talk about some things that say, how should we provide help? What should we do to these people? We'll try to come up and talk with that. And you can see that this is a very healthy aging. Even there's a decline. Now, another thing that has come up recently, and being a cardiologist, I'd probably said I'm prejudicial in this, but the question comes up, could frailty, could sarcopenia be a cardiovascular disease? The reason to think of that is that these people frequently have some risk factors that the person with coronary disease would have. First, frailty is more common in women than men. Now, a lot of times people come back and say, well, it's more common because women live longer. But does not seem to be the facts. It's more common in African Americans. It's more common in the obese patient. And again, you can lose some muscle mass, but you might replace it. Your muscles might not get smaller because you're replacing it with fat. These people are less physically active. They frequently have an elevated A1C. They're more commonly smokers. And if they have an ankle brachial index that's wrong, they're 3 times likely to become frail. These are all things that you can look at and see that people are more likely to have, diabetes, or at least be resistant to glucose in this group of people. Now, this is what is said about the prevalence of frailty, is that if you look at it, it's thought that people rarely become fully frail before age 80. But you can see what about age 80, what it begins to happen. And it begins to rapidly climb. The other thing that you can see is the thought is that the human race, the people that study aging, can probably live to about 104. And at that time, that we've exhausted our ability to continue. Some people say it's even shorter than that. You certainly see examples of people that are living longer than that, but that's the one that has come. You can see as you go through the aging pattern is that there's a certain percentage. It varies anywhere from about 10% up to about 25% of people that are frail. 25% of those over 85 are frail. And this just shows a percentage again that of the population at that time. More common in females, as we said before, more common in African Americans. Frailty has a face, and these are all people, most of them are people that you'd recognize. We've got 2 former presidents there. Both of them, at the end of their life, had become frail. We're not seen in the public much. Now, one difference, and one thing that comes up in frailty is that clearly you would see that you go through and you could have frailty with just physical frailty, or frailty that is characterized by dementia at the same time. And you can see this is John Paul II, who was a very good athlete, very robust until the last decade of his life. And this is a gentleman that from the UK, he was beginning to realize he was getting weak, but his wife was far ahead of him. He murdered her and did suicide because he didn't think that they could live very long successfully by themselves. And so it can bring up some very sad stories as you look at this. Now, this is another term that I think we have to think about is elderly versus frail. Nature never draws a line without smudging it. And what they're saying here is that it's not as discrete between being just elderly and being frail as we'd like for it to be. The line gets blurred at times if you're doing this and not doing that. And the interesting thing is who said this quote. Does anybody in the audience know who said this? Winston Churchill. Interesting. So if we look at the thing with frailty, what we're saying is that frailty is not a condition that you pick up very quickly just by seeing in the presence of a person. And so how do we try to do this? And so people are working on trying to get frailty scores, trying to get a way that you can look at it and score somebody and say they're very frail, because then we've got to try to intervene. Right now, we do not even know how to pick out people that are frail very well. You need a method that's easy to calculate, easy to obtain. Generally, it would probably have to be obtained by non-physicians just because of the time it would take to do this, and it has to be highly predictive of adverse events. At this point, we're not sure of any of these things. We can train people to do it, but what is the test we want to do? And this is what you face with this. The consensus of the defining characteristics, there is no consensus. There's an absence of agreed among measures to do it, and there's a lack of predicting its prognosis. So if you came in and found somebody that you said, this person fit my criteria for frailness, you don't know what you should do necessarily to try to help them, and you can't give them a very good prognosis. These are three of the things that have been used, three of the scales that have been used to assess frailty. And Freed is one that says that she has to have three or more of these characteristics, either unintentional weight loss of 10 pounds past year, self-reported exhaustion, weakness measured by grip strength, slow walking speed, decreased physical activity. So if you had three of those, she says if you have two, you're pre-frail, three, you're frail. Again, you can see some things like exhaustion are very qualitative and subjective, not very quantitative. And so that's part of it. Rockwood and Minitsky, they did the health deficits. They have about 140 different life activities that you could do. And then they do the percentage of the number that you cannot do. And so it depends on your percentage whether you have this. This is thought to be the most accurate of all the health assessment and frailty assessments, but it takes so long it doesn't go over very well in offices. And then the frail comes back, and they use a similar type of thing to the Freed thing of looking at three or more of these characteristics of fatigue and difficulty ambulation and strength. And these are just some of the things that I think that you come through as you try to do physical activity. And the YMCA, just up around the block up here, does a good job with this type of thing. There's activities that you can do and try to keep these people busy. The interesting thing is that the only thing that has shown any hint of trying to help frailty is exercise. That it doesn't now. The Mediterranean diet is some proponents of that and say that make a difference. But the only thing that comes out is to keep these people active. And again, you have to catch that before they get further along. These are some other things that he said. Promote physical activity. And one person says this, and I think it's a good thing, is don't try to get them on a 30-minute or an hour exercise program. If you can do not necessarily exercise, but just have them be active more. To get up and walk across the room to turn off the TV, or get up and pick up a bucket and water the flowers. Or somebody even had set up to try to have a game with their parents that they would leave jars that had a tight lid on them and ask them to see during the day while they were there by themselves how many of those lids they could get off. And just something to keep them busy and going is important. You have to be mindful of these two things at the bottom, and they come to be tough when you're trying to deal with people that are frail. It's survival versus safety. That you want to be safe and try to prevent everything, but if you make it where the house is such that they just find it very unpleasant to live, you're not accomplishing much. And then neglect versus freedom. You want to give them some freedom, but you don't want to just neglect them and not paying attention. So these are things that are difficult as you try to work through this. Again, things we've talked about as you do. Now, as you look at the elderly, and this is going away a little from the frail group but to the elderly group, and you would see that we as physicians need to start thinking more about practicing medicine, particularly internal medicine, on the elderly population. That we tend to use the same drugs, the same doses that we use on people that are much younger. And like this is a recommendation for type 2 diabetes, and it came out from several different diabetic groups. That if your A1C, have it 7.5 or less if you've got 3 or more of the conditions that lead up to frailty. You can even go up to 8 if they have greater trouble, and either 8.5 or 9 if they're really fully frail and have cognitive dysfunction. That it's just And nobody's coming in saying that this is the gospel, this is what you have to do, but they're just saying, wake up and don't continue to say, I've got an elderly person, I'm trying to get that A1C down to 6.5. Hypertension, again, similar thing is don't push too hard on that, because be afraid of orthostasis, be afraid of syncope, because this can cause you some trouble. And that you can use this to let your blood pressure be 150 over 80, 140 over 90 in the older person. Another thing that's very important in the frail is socialization. And that is that it seems that those people that have some social activity, that participate in something with other people, whether it's just going and sit in a room while somebody plays a piano, or while it's walking together as a group or something, that makes a profound difference. The evidence is not as strong as it is for physical activity, but it does suggest that there's a problem there. So this is where we stand right now, I think, as you look at it, is that frailty is important to recognize. We still have a question: if we recognize it, what do we do with it? And besides physical activity, besides looking at your medications and making sure you're not harming them with some of your medications rather than helping them, and you're trying to improve their socialization, is important. We've still got things to look at as we go through there. Now, there's one other thing that somehow the slides have gotten mixed up. Another point that I wanted to bring up is the biggest thing that you face with these people generally is pain management. And so we're facing, and right now, they've got the opioid mission going, trying to go get it off the ground and go full steam. And I think that's something all of you have to be able to recognize and see what drugs you're taking, what drugs you're using, because you can go and listen to a lot of drugs that you don't even know that they're opioids. Tramadol, Vicodin, Percocet, Percodan. These are all drugs that are opioids. The group that is the highest likelihood of dying from opioids is a group over 65. And I didn't realize this until I was looking at that, but that's the number, and it's just because these people come in, generally they're going through a transition of life at that time, they're facing changes in life, they could be a little depressed. Opioids are not generally pain relievers. They change your perception of the pain. They make it where it's more comfortable. They make you where you feel more relaxed and feel more comfortable. And so it does a lot for you besides just to decrease the pain. And while it decreases pain, it doesn't obliterate the pain. But it makes it where you can accommodate it and accept it. And that sets you off into a situation that it's easy to slip into taking these many things. And you look at what I see is I see patients that are brought in, and we see them from on referral or something. A number of them that are taking some form of an opioid, it started when they had knee surgery or back surgery or cardiac surgery, and not just the surgeons. They came in, and you face them with terrible hip pain, can't walk because their hip is hurting, and nothing else is working. Then you've got to go through the gymnastics of saying, is this pain I've got to obliterate, or is this pain that I'm going to let them have? And that's a hard decision. The other interesting thing about it is that much of the opioids are combined with other drugs, such as aspirin and Tylenol. An interesting thing on those drugs is that there's no standard for the amount of the non-opioids that go into the medication. And so the amounts can vary very similar. Also recognize that, again, women are more subject to having difficulty with the opioids than those that are not on those. So I think as we look at this situation, is the things that trouble me about it is, one, it's very common, increasing dramatically every year, and for the most part, I think medicine is doing little about it. The other thing that we see as we face this is we got this thing of frailty that to this point we are not dealing much with. And so we don't know if there's anything we can do to help except maybe exercise. We don't know well how to recognize it. We've got several different pathways that you can try, but none of them have been proven to be particularly good. The one thing that I would say, our surgeons here, not the vascular surgeons, but the urological surgeons and anesthesia, and Paul Garcia was one of the anesthesiologists who was going to talk some about this, but he got called away, is that you've got these people that are trying to give this evaluation pre-op and say, I'm going to assess whether this patient is frail or frail, and try to treat them differently. That is, if somebody comes in clearly frail and needs extensive surgery, then they might postpone them for several months and put them through some type of physical exercise program to get this done and to improve it. But at this point, again, we don't know that. So our hope is that here we can start trying to do something, at least identify the people. Can we come out and say we identify these people, that these are frail people, and then follow them and see if there's a difference in their longevity or a difference in their health from that point forward. So that's what I did. Could we go back? I had some patient data on the first. Can you go back to the very first? Well,
what was it titled?
Okay, this is what we face. Is that first I've got a 78-year-old woman that comes in, and she is the most active person in her family. She goes to Shepherd Spinal Clinic, and the way she gets in there is she's got a son that has MS, and so she goes with him, and she goes and swims 20 laps 3 times a week. She cooks all of her meals. She lives alone in her house. She cooks her meals and frequently asks her son over and prepares his food. She takes care of her house, and she has coronary disease. She had a previous bypass surgery. Rather spunky lady. The last time I saw her, or next to the last time I saw her, I told her we'd seen her and said, "You're doing well, and I'll plan to see you in 6 months." She turned to him and says, "Doc, that's way too early." Says, "I'll see you in a year." And so she went out, and then what happened about 6 weeks ago, she had an acute coronary syndrome, got severe chest pain, dropped her pressure temporarily, but it came back. She came out with some heart failure. Ejection fraction was in about 35%. And her son brought her into the hospital. After that, she came in the hospital for that, but then she was coming back for a follow-up visit. And now she's quit walking. She says, and you ask her, why you quit walking? She says, I don't know. I don't have any more interest. She still goes with her son to the swimming pool there, and will sit down and just sit there. Now as you're trying to figure out how to treat this patient, you say, one, is this depression? And do I treat the depression? Is it something else? And there was other interesting thing about a week ago in the New York Times. One of the editorial writers was writing about his mother. It was almost the same story. Woman had been very active, doing everything she wanted to do, taking care of herself and others, and then she had a ischemic event, and she's quit doing all activity. Says she has no interest. She says, I could do it, but I don't have any interest in doing it. And that's kind of what we're facing in a lot of these people, is how do we treat them? How do we get them back on their feet, or is it over with? And we don't know that. We don't know what the outcome is with these people. We do know that they, untreated, unaddressed, if frailty is unaddressed, they don't live long. They live, average life expectancy, we said, is about 2.5 to 3 years. So that's the kind of thing that you see. I'm impressed that there's some people that seem to fly right through this and have no slowdown, no problems arise, and they do well without ever developing frailty. So it's one thing to say that, and some people say that frailty is just a trip to mortality. that there's no rescue, you take it and you're going to die. But I think there's no evidence to say that there's nothing we can do. The evidence is that there's nothing much that we've tried to do, and I think that that's what we've got to address. So I'll open for questions and comments, and see, I apologize that those other two patients didn't come up. Any questions, any comments?
It's on.
While he
on.
says that, and that's another
on.
point it's worth making, is that it's not clear whether frailty includes dementia. That some people separate frailty out as more of a physical thing, and dementia is not part of it. Others, again, because of the confusion about the whole thing, says, well, no, dementia should be part of the frailty syndrome.
It's working now? Okay. I didn't have this question. Apparently I'm the chief resident because Ted Johnson, our chief of geriatrics, texted me from another site saying, please ask Doug this question. So that's my role today, Doug.
Okay.
So Ted writes to me, for you, Doug, you've met with patient family advisors about frailty. Do they understand the concept and feel frailty is important? What advice do these patient family advisors offer us about discussing frailty with older patients in the clinic?
Well, no, they don't. They don't understand it. And the first thing that gets off with the frailty people, is they get confused about frailty. Is they think that frailty means it is clearly visible that this person is having trouble. That is, if they're coming in, they can hardly stand up, they use canes or crutches, or they got braces on or something. That externally, that's not primarily what we're talking about. The frail patient is a person that comes in looking like, a normal person, elderly but normal person. And then you put them against some obstacle, and they do not have the reserve, that they crumble. And some of my friends are vascular surgeons or cardiac surgeons. They always have said in the past, says, boy, it scares you because sometimes you look at somebody and they look good, and as soon as you unzip them, you find out that this is a different story. So I don't think we talk to patients good. And I think that another thing is that trying to talk to them and say, these are the things that you are facing, how do we help you? And I think the exercise thing is important. You learn from your patients. I was using the word exercise, and the patient the other day says, you shouldn't use that word. Says, it's not exercise, it's activity. What you do is activity. Don't make me say I've got to do some exercise, but just have me more active. And another study comes up and says, if you can get 10 minutes of activity several times a day, that's probably better than 30 minutes at one time because the patient doesn't get so tired. And so I think that what happens is, another important point that you should say on this is, as we deal with these older people, we often get so in tune to try to find is what is the matter with Mabel rather than what matters to Mabel. And that's what you've got to say is, okay, what is the thing that is bothering you? What do we need to help? You're not going to make them live longer for the most part, and they realize that. But I think you've got to inform them that you're interested in them and you're going to try to help them. Long answer to a short question, Tom.
Thank you, Doug. I was your last point that was along the lines of what I was thinking too. Is so many times in my personal experience, I met with a patient who's on one of these downward trajectories. Either it's just that steady decline, or maybe something abruptly seems to have changed for them. And there is this bit of a struggle in my own mind, and often in their minds or their family's minds, about how far do we go to pursue an underlying cause that might be treatable or reversible. Because as we know in the elderly, their presentations for even common illnesses may be very subtle and atypical. So I wonder if you have advice or if there are strategies or guidance on how do we navigate that, and are there strategies that are effective? And since Ted's out there in the ether somewhere, maybe he can text Dave his response too.
Yeah, we'd be glad to hear, Ted. I think the thing that find is that just talking to them and trying to find out some things. I also do is have them frequently, if they get old and they're having some trouble walking, have them walk down the hall and just watch them from both the front and rear and see how they're walking. And they don't have to walk long distances. It can become apparent there. But I think the most important thing is just understanding from them what they're looking for. Because most of them realize that time is not on their side.
I just want to tell the faculty I'm not the chief resident. Now I have Jeff Lennox texting me a question.
Okay.
But I guess I'm happy to play the role. So Jeff has a question. I'll preface it by commenting that I don't know if you've ever read Lewis Thomas's book, Lives of a Cell. It's a wonderful book, and he has a chapter where he says, "My mitochondria take me out for a walk."
Yeah.
And that, mitochondrial dysfunction, you talk about frailty and sarcopenia. So Jeff asks, is decreased mitochondrial function part of this, as has been identified in his world in people with HIV, where between the chronic infection and then perhaps some of the drugs are on, they have mitochondrial dysfunction. And I know from our research that sarcopenia or premature sarcopenia and frailty is actually the most common cause of disability in people living with HIV. So Jeff is asking, is mitochondrial dysfunction underlying all this? And
well, it might be. I think that's where we are, is that the research is lacking on this entity. First thing you got to recognize that we're talking about an entity that's 20 years old. I mean, 20 years ago you didn't see much of this because people didn't live long. And so we're talking about something relatively new and something that to this point has not attracted a lot of attention. It said that in 1980 there was about 10 articles submitted for publication. And then, in the last decade, it's jumped up to about 2,500 articles on it. So it's beginning to get some attention now, but it hasn't had it for a long time. Bob, you have any thoughts on that, on the muscle? Okay. Any?
That's all I got from the outline area.
Okay, well, thank you.
All right.